Can you hear me? Yeah, okay. This session is about e-rehabilitation, and it is called Current Status, Benefits and Challenges. My name is Gunhild Rothwald, and I am from the Norwegian Center for E-health Research. I'm replacing Paolo Sonoboni, who was supposed to host this session here. He's unfortunately not able to be here, so I'll do my very best. We are going to have 4 presentations, and all presentations are from projects conducted in Nordic countries. So we have a presentation from Sweden, Denmark, and from Norway. And but first, I'll give you a short introduction about e-rehabilitation. What is e-rehabilitation? It's a very difficult word to say. E-rehabilitation or tele-rehabilitation is rehabilitation by use of information and communication technologies. This is an alternative or supplement to ordinary rehabilitation. It can be done individually or in groups. It includes both adults or children, or both. And providers are different kinds of health personnel, family members, or other caregivers. The kind of technologies used can mainly be divided in 3 categories. We have image-based technologies, both real-time, like video conference systems, and store and forward technologies such as photos, videos. And we also have these automated algorithms and interactive modules. And the second one is sensor-based technologies, in which you can do different kinds of measurements and also self-management tools. And third, you have virtual reality, which you can use in various kinds. E-rehabilitation is a quite new field, and there has been some research studies, but not much. And Paolo Sonoboni has, together with other fellows, research fellows, done a search in PubMed, and they have found 17 systematic review articles and 19 random RCT studies that has been conducted within this field so far. And as you can see, there is an increasing amount of research in this field going on. And we will be presented for more of that in the presentations today. My last slide, I just want to mention an RCT study which has been conducted for the 2 years that has passed. It's a collaboration between research organization in Norway, Denmark and Australia, and 120 patients has been through this trial. The intervention has just finished, and the results will be presented during the next half year to come. So that will be very interesting to see when the results are ready to be presented. I'm going to introduce you for the first speaker, and that is Birte Dinesen from Aalborg University in Denmark. And Birte is going to talk about pros and cons on tele-rehabilitation of patients with heart failure. So the floor is yours.
Thank you very much. Can you hear me? And thank you for being here. It's a pleasure being here today at your very nice conference. Can I have the presentation on, please? I would like to talk about heart failure and tele-rehabilitation. I've been working with tele-rehabilitation of patients with COPD and heart diseases for over 10 years now. And I'm happy that we can be here today, and we have established this new network that we will hopefully you will hear more about in the future. Heart failure is a patient group that we have over 55,000 in Denmark, 26 million worldwide. We know when heart failure patients have been admitted to hospital half a year after, 50% of them are being readmitted to the hospital. We know living with heart failure is a very hard condition. You can very often get swollen feet, get water on your lungs, and get very quickly to the hospital. So it's very important. And it's also a field where we've done a lot of telehealth over the years, but we haven't succeeded because doing telehealth with patients with heart failure, the literature is very conflicting. Even a clinic in the United States, where they have a lot of experience on, they stopped a big study with 3,500 patients because they didn't have any significant results. So at our study here in Denmark, I would like to tell you how we have, in a very close collaboration with 4 municipalities and 4 hospitals, at the time when I came and asked them if they would like to join our study, they have moved all rehabilitation of the heart failure patients from the hospitals into the municipalities. And by doing that, they had a higher participation rate, they could reduce readmissions, and then also had a higher quality of life. So I came and asked them, would you like to join our study? The target group for this study are heart failure patients in group 3 and 4, and patients who are able to take care of themselves to a certain extent. I don't want to go all into details of the state of the art, but the literature is really conflicting. And in 2010 we had a study that has been very discussed all over the world. In this study of Chandra in the Journal of Medicine, 25% of the patients, no, not 25, I think it was 14% did not use the system. They had technology set at home, but they wouldn't use it. So I think these patients we can learn a lot from. Why wouldn't they use it? What was the matter? So in our study, we wanted to do it differently. So our point of origin was that, well, measuring blood pressure, pulse, and weight is not enough. What about could we, if we looked at patients' physical activities, what about their sleep, and what about their well-being? And that's what our study is about. So our hypothesis is that if we can measure some of these values, will we be able to teach the patient better to take care of themselves? So the purpose of our study is that we have designed a tele-rehabilitation program in collaboration with the users. So we hope that we can give the patients a higher quality of life, and we hope that by multicentric measurements that we'll be able to give the patients a better feedback. So we did user-driven innovation, where we had all the stakeholders helping us, developing us this program. It's very important when we design all these solutions, and a newly paper published in Games for Health 2 weeks ago said that there's really a lack of theoretical frameworks when we are designing. A lot of software engineers that can make these apps for us. But if we don't think about making them interactive and that we can do behavioral change, then they're not worth anything. So in our study, we have built in, we're working on a theoretical base called self-determination theory, where we work on autonomy, relations, but also the motivation of the patients. And we have worked on that from the very beginning in collaboration with the Department of Psychology at Aarhus University in Denmark. So we have built a system where patients at home, and when you go to rehabilitation in Denmark, of course, we're following the international guidelines of cardiac rehabilitation, but it's also important, we know we have a fragmented healthcare system in Denmark, so it's important that they can exchange data. So we made a heart portal where patients, when they are measuring their data, like steps and sleep, blood pressure and pulse and weight, that both the healthcare center and the hospital can see it, and also the GP. So we built a 3-steps program built upon tele-rehabilitation. So the first step is the phase where the patients are having their medicine adjusted. The second phase is where they are at the healthcare center or they can train from home, because if there's a long distance, they don't need to go to the healthcare center. And then there's a half year of follow-up where they're being followed digitally. Here are the technologies we're using. It's the typical blood pressure, pulse and weight, but also a sleep sensor, MFit from Finland, and then they can choose between 2 step counters and they have a tablet. So we say that we have given the patient a digital toolbox. So here they have an information side and they can look upon their values, but we are also the first in Europe that are working on patient-reported outcomes, where the patients every second week are answering an online questionnaire, and it's a validated questionnaire within heart failure we are using. We have over 80 videos. The texts are in different levels because we want to make it individualized for the patients. They can see their data, sleep, daily steps. Here are the patient-reported outcomes. Patients have validated all this, and we have published on the usability of our heart portal here. We're doing a multi-center randomized controlled trial, and we have 140 patients participating in this study. Our research focus, I won't go much into details, but it's quality of life, but also e-health literacy and how they experience rehabilitation as a coherent process between hospitals and healthcare centers. We work on developing an algorithm for the heart failure patients, and I have a PhD student who is finishing his PhD at the moment. But that's in order because we produce a lot of data. And it's very important that we look at this as it's going to be a warning or a reminder. So we are talking about what is the best case for the patients. So we have a very closely dialogue with the patients. So now when the patients are participating in this, what are the pros and the cons? Well, the patients said, well, it's very nice because it's individualized. And they like it's not a traditional just one track you are going at. Here we can individualize. They also say that the rehabilitation activities are better integrated into their everyday life. And they think that it is as good as being at a healthcare center. I've done a previous study where we're publishing a randomized controlled trial, and here we have the evidence as well. So patients, they say they don't need to be in a healthcare center in order to do rehabilitation. So here we might have, like in the first slide from Paolo, it can be an alternative or a supplement to rehabilitation. Patients, they also save time, and if they are working, there are still patients who are working even with heart failure, with COPD. So here they can save time and maybe look at their job at the same time. Some of the consequences are that patients find it hard maybe to motivate themselves. That's one of the things we're very interested in the COPD study that Hilde was presenting in the beginning. And there are still patients who think that the technologies can be hard to use. How do you set up a Fitbit? Of course we help them from the project, but how do you look at it? So there are still some technical issues. So we still need to give the providers feedback on making user-friendly technologies. And then also the fact of motivation over time. In the COPD study, we have had patients training for over 2 years in Norway, Australia, and Denmark. But in fact, and I think we are the ones who have had patients doing rehabilitation for over 2 years, the longest intervention in the world. But it seems like it hasn't been, at least for the COPD patient, it's been good. But here for the heart failure patients, they think, oh, now I feel well, then I'm not sick. So it's like, do I need then to be in a tele-rehabilitation program? So that's why we also call it a digital toolbox that they can go forward and back to if they need it. What we have tried to do in this project is to teach the patient in another way to be aware of the symptoms, because normally I think if there are doctors and nurses around here, it's the weight scale and your blood pressure and your pulse if you are a heart failure patient. But in this study we have asked them also to look at their activities, physical activities, and how they sleep. Many of the patients, they sleep with a lot of pillows under their neck. So this has been very different from them. And So we're looking very much forward to have our results. We will have them next spring. So this was some of the first pros and cons on telerehabilitation, and here are the project partners, and we are sponsored by a private foundation in Denmark. So thank you.
Are there any questions?
You will have to help me, Gunhild, if somebody is raising a hand, because I have two lamps here.
I will. Okay. Thank you very much, Peter. Okay, the next speaker is also from Denmark. We're going to meet Charlotte. Charlotte Simoni, she's from the University of Southern Denmark in Odense. And her presentation is about a study of COPD patients with focus on what should be addressed in tele-rehab.
Yes, thank you. And thank you very much for letting me be in here. I'm going to give you a presentation of a qualitative study that we did last year. We are doing, oh, sorry, this is my first slide. We have planned a program called COPD Life, which is a tele-rehabilitation intervention for patients with COPD. But before we planned this, we conducted this qualitative study that I'm going to tell you about in order to get in-depth insight into what are the experiences of COPD patients when participating in standard pulmonary rehabilitation in order to clarify what should be addressed in such a tele-rehabilitation. We already knew from the literature that there is, even though we have a quite good pulmonary rehabilitation in Denmark, as in Norway and many other countries as well, we knew that there was room for improvement. According to the literature and the policy of the Danish state, we were eager to plan a program where we could offer services for the patients with good coordination between the hospitals, the specialists in the hospitals, and the healthcare people, professional in the municipality. So we knew that we were going to have a well-coordinated program for the COPD patients. We also had a hint that maybe the standard length of the pulmonary rehabilitation, which in Denmark is about 8 weeks, maybe was too little, and we expected to plan to have a longer-lasting program. We also wanted, according to the policy and the philosophy of the healthcare system in Denmark, to support the COPD patients in order to be strong, to choose and between the services in both the sectors. We didn't know either how to do this, but this study was conducted in order to be very clear about what are the specific needs of the COPD patients. Our intervention or the program is guided by the MRC guidelines, because this was, we considered a complex intervention. So we did a study of the standard pulmonary rehabilitation in Denmark, which is a standard program according to the national guidelines. I guess you recognize this program from your own countries. The overall aim of this study was to gain this in-depth knowledge of how the patients perceived and experienced the rehabilitation, so that we could see what was essential for the patients in our program. What should we do? What should we strive for? And what should we avoid? We included 21 patients, 11 men and 10 women, and that was coincident because we asked people when they met up for the rehabilitation, do you want to participate? But luckily it was so close in men and women. I myself conducted participant observation. I took part in the rehabilitation sessions, both the exercise training and the education sessions, and also I met before the training and were among the patients and listened to what they discussed and what they said and how they looked and how they fought with their breathing actually. And we made also interviews at the end of the course and made a phenomenological hermeneutic analysis guided by the philosophy of the French philosopher Paul Ricoeur. We also measured some things in order to be able to know something about what how this study how the standard rehabilitation works, how the outcomes are, in order to compare with our new program. And this is the preliminary findings, which are about to be published in 3 papers. And we found that the patients were quite challenged by their diseased body, both according to the dyspnea, but also because of a lot of other inabilities. They struggled with pain in the leg, pain in the back, pain in the knees, and therefore they had troubles by following the exercise trainings because of those inabilities. But overall, because of the breathlessness or the dyspnea. And actually, we found that the patients were like a mental and physical state of being was like they were used to avoid doing things that made them breathless. So doing exercises was a demanding new thing for them, and they needed intensively guidance from the physiotherapist just to be able to do the techniques in the training, but also to convince themselves that this is okay, it is okay to feel dyspnea and work on, and then go for a new state of well-being. Yes, so that was one of the findings. And of course, they were quite unfamiliar with doing exercises because daily living for them for several years has been like avoiding feeling breathlessness. We also found that they were not able to call for any help when they have clinical aggravations. If they coughed more than they were used to, or they had phlegm in the lungs, they told me that they were just waiting for it to pass over. So they were not into that they had to do something when they felt some clinical changes, unfortunately. We also found that they were very heterogeneous. So they didn't need and they didn't benefit from the same exercises, and they were disappointed if they did not have a competitive milieu in order to go from where they are to a better place. We also found that they find a very rewarding fellowship in being with peer patients, and that they learned together, they laughed together, and they shared the feelings of having this disease, which many of them didn't was aware of in quite a clear way. We also found that they had a lot of benefits from guidance from using the PEP device, the little plastic things, in order to have better breathing techniques, or also the breathing techniques overall. But some of them learned to manage and others didn't. And the one who learned to manage was happy and found a kind of inner peace, for example, when going to sleep. But those who didn't, who saw that others did, they were very disappointed and actually filled of hopelessness, because why can I not learn this thing? And they expressed clearly that 8 weeks was a nice time to be together with other patients, but it was not enough in order to change exercise habits, in order to learn to have the good breathing techniques, and in order to learn about what to do when I have a clinical aggravation. What is a clinical aggravation? So they felt like lost in the world when the program ended, and they didn't have the surplus of energy in order to plan what to do now. So they felt like very much left alone. It was also demanding for the patients to even arrive at the hospital in order to come find a parking place, which there are not a lot of in our hospital, and to park the car and to go to the training sessions. And often I met them fighting with their breath and using up to 30 minutes in order to have the breath under control before they were able to train. So it was quite demanding for the patients to come to the hospital. Also, they mentioned that they were afraid if they felt a little ill to be infected from other patients or to infect the other patients. Lots of them was admitted to the hospital due to the lung disease, due to other diseases, and then they missed sessions of the rehabilitation. Also, I saw in the sessions of education that the program was like 4 hours of education, sitting on a chair, listening to a nurse, to a dietitian, to a physiotherapist, and sometimes having dialogues. And we found that merely the first 30 minutes they were able to sit down and listen engagedly and have an outcome from this session. But the rest of the day they were not aware of what was happening, and they were not able to be focusing on the education session. We also saw it in the exercise sessions. Over the span of time, in each session, they lost their concentration and wasn't able to listen to what was said and to receive invitations from the professional, unfortunately. So, as an overall finding, the pathways of participating in standard pulmonary rehabilitation was quite demanding, and we saw that there was certainly room for very much improvement according to this. So this is the sum of our plans for the program of the tele-rehabilitation that we found to address according to the study. Of course, a longer lasting program was desired. Flexibility in time and place, and here the interactive tele possibility was very welcomed by the group. also individually focus and help in order to support in order to endure everyday life better than they were used to was very much needed. So we decided to keep to the philosophy of empowerment as our main philosophy, as our main approach in the program. We also decided to have short sequences and repeatedly sequences of education in order to repeat what was said and to ensure that everybody heard what was said and were able to participate in the important dialogues about what was discussed and said. We also found that they needed access to individual consultations, and as a very important point, they needed access when they needed it, not when the hospital or the municipal staff wanted it, but when they needed it. So actually we invented to have a telephone where they could call and they could say, can I have a speak to the nurse today or tomorrow because I need this and that, and we organized it this way. Yes. And then, of course, we wanted them to have this rewarding room for peer fellowship, so we arranged them to be able to be in the tele sessions together, so they could discuss things together and even invite their spouses or other relatives in shared sessions in order to have this fellowship that was that is obviously very rewarding to the patients. So this is some of the focus spots in our program, which we are going to analyze the data from the next months. We thank for the patients and the steering group and the research group. This is the steering group from my home place, and this is the research group. And we received fine fundings from those foundations, which made it all possible to do the program and test the CLOD Life intervention for 1 year. Thank you.
So if there are any questions, you either have to shout or I could run the stairs and give you the microphone. It's a little bit difficult to see, so you just have to give a very visible sign if you want to ask. Okay. Both Charlotte and Birte is here for the lunch also, so I guess it's possible to...
Yeah.
Okay.
Yes. Can you shout up? Or?
Yes, I try to transport. I wondered, did you involve the GPs in any way in this rehabilitation program?
I cannot...
Did you involve the GPs in any way in this?
No, I wanted to. Yes, you asked if whether I involve the GPs in the program, the tele-rehabilitation program, and actually I wanted to, but they didn't want to. I hope that this will be a part of the next project, because this is, as I assume you indicate, a very important part. In the program that we did, we have a physiotherapist, occupational therapist, a lifestyle coach, and an expert from, we have a center called the COPD Competence Center in Region Zealand. And what was important was to have those healthcare professionals from both the hospital and the municipality to work together and to support the patients. Yes. Thank you. Oh.
Thank you. I would like to ask you, have you considered taking along also the people who are close to these patients? So people who live with them, or
Can you say that again?
yes, so people who live with them, or their partners, I don't know, their children, people who can support them, for example, to keep going when they have to do their exercises.
Yes, you're asking whether we were wondering to bring in the relatives in the exercises and the education sessions, and certainly we did, and that was also a possibility with the Tele set up to invite spouses or children in order to see what they were doing during the exercises, what was really important, we found out in the next study, was for the relatives to have somebody to talk to, or other relatives, or to have to dialogue with the other patient, with the peer patients, and we found a very good dynamic by using this. Yes. Okay.
Thank you very
Thank you.
much. Next speaker is Karin Wadell, and she's from the Umeå University in Sweden. And she will present us for a website and present some of the research about how they have developed this site. So, the floor is yours.
Right. Thank you very much for letting me be here and presenting the results from our research around Kolwebben. That is an e-health tool for people with COPD. As you know, COPD is a very common disease. It is the third most common cause of death worldwide. In Sweden we have between 500 and 700,000 persons estimated to have COPD. In Norway, I just noticed you have 150,000 people with COPD, so I don't know about the estimation, because many people live with COPD without knowing. But I'm sure you are aware of that it is a huge problem. I am a physiotherapist, and I have been working with pulmonary rehabilitation for more than 20 years. One of them here in Norway at the Glitre Clinic, which I really enjoyed. That was a fantastic environment. And we know that I have done studies, but many others have done studies over the years, and it's a huge load of evidence for the benefit of pulmonary rehabilitation for these patients. We know that it decreases symptoms, it increases their physical capacity, improves their quality of life, decrease healthcare use, etc. It is really a good treatment, and it is recommended. This is just a slide to show you how cost beneficial it is. QALY is life with good quality of life, and as you see here, the most cost beneficial you can do is to give this population flu vaccination, and thereafter you should help them to stop smoking. Following to that, it is pulmonary rehabilitation that comes as most cost beneficial before the available pharmacological treatment today. This load of evidence for rehabilitation or for non-pharmacological treatment for patients with COPD has been noticed in the new guidelines from Socialstyrelsen in Sweden, where many ingredients in pulmonary rehabilitation has been very highly prioritized, like test for exercise capacity, like the 6-minute walk test, exercise training in patients with COPD, in stable phase, and also in connection to exacerbations, nutritional support, education, occupational therapies, everything that is sort of mostly included in pulmonary rehabilitation. This is great, this is really good. So when we know this, we know this national recommendation, and it's the same in international recommendation, that pulmonary rehabilitation should be offered to this group. Everyone benefits from that. We did a survey in Sweden to see how many hospitals that gave pulmonary rehabilitation in Sweden. And the black dots, as you see to the left, are hospitals that don't offer, or didn't at that point, offer pulmonary rehabilitation for patients with COPD. And the red dots are the hospitals who did offer. We had a 99% response rate, so this is pretty well covered the country. As you see, the northern part of the country is somewhat sparse with hospitals offering pulmonary rehabilitation. And I don't have a pointer here, but I live up north in Västerbotten County, where there are 3 dots, 3 hospitals offering pulmonary rehabilitation. What we found there was surprisingly low. Not even 0.5% of the Swedish COPD population received pulmonary rehabilitation at hospital, which is the recommendation to give to these patients. What we also found was that 1/3 of the patients that were offered PR declined to come, which was very, very frustrating for us, of course. We did another survey in primary healthcare, which is also a big actor in the care of these patients, where we looked at availability or access to different professions that could give pulmonary rehab in primary care. And the access to these professions are, as you see, pretty high. We looked at 4 different places in Sweden: northern part, middle part, Stockholm, and southern part of Sweden. And as you see, for the different professions, except for dietitians, it's pretty high coverage of those rehabilitation professions. However, when we looked at how they offered rehabilitation for COPD, it was lower. So also in primary care we have a lack. We also did a PhD student of mine who actually defended her thesis this Friday, so it's available on internet, COPD in primary care, made this study where she looked at healthcare professionals' view on COPD care, and they reported that they have lack of competence. They have problems with the organizational work. It is difficult to know what to do and when to do and who should do it. So that's why the title, COPD Care on Shaky Ground. And this was also the background for us to recognize that we have to do something. And of course we fell into the field of e-health. So we decided that we should design an e-health tool to be able to do something about what we have found in previous studies. And from what we heard this morning actually about co-creation, we decided to use that. So we involved healthcare professionals, patients with COPD and their relatives, and also researchers externally from our own research group. All of these individuals were taking part in individual interviews and focus group discussions. And during that period, we were, as you see here, we made mock-ups and pilot films according to their wishes of what they want to have from an e-health tool to use it, both a patient perspective, relative perspective, and healthcare perspective, and also external researchers. And from this, we developed continuously, by using help from them, we developed a prototype for a web page that finally came out to ascoolwebben.se. And that design process is just recently published as well. And what we wanted to do, or how it ended up, these are just screenshots. This is a screenshot from the patient side, patient view of the web page. This is everything on the web page origins from the recommendation of the Socialstyrelsen. So it might be a little dry, but we wanted to be very sure of that it should not be any pharmacological affecting companies in this, so it's only what is in Socialstyrelsens guidelines and also Läkemedelsverkets recommendations. Just examples of what you find at Coolweb, and I did some screenshots here. This is from healthcare professional side of the web page. With, as you see, there's a lot of different self-management strategies according to evidence that you can find there. Also, as Birtes talked about a lot, what came up was that they want films. They want to have films for both the patients, how should I do it? I want to not just be told, I want to be able to look at that 100 times if I wish. And also the staff wanted to have films to be able to explain for the patient and show the patient. We have many films also of COPD patients telling their story about how they cope, how they live with their disease. And we did a pilot study on this a few years ago with the aim to evaluate this webpage, of course, to facilitate self-management strategies for persons with COPD. We included 6 primary care centers, and we looked at people with COPD, but also staff or professionals. However, we don't have the results analyzed yet for the staff. All patients received information about benefits of physical activity and a pedometer, and the intervention group received access to Coolwebben as well. We followed them for 3 and 12 months, or the follow-up was there. We found no effect on symptoms measured with COPD assessment test, or dyspnea, or generic quality of life. Though we found increased self-reported conceptual knowledge in self-management strategies like how can I be physically active, how can I do exercise, how can I use breathing techniques at rest and in activity, and how can I use techniques for mucus secretion techniques, secretion mobilization techniques. And we also found increased self-efficacy for physical activity. Physical activity, I forgot to tell you, is one of the most important predictors for mortality. That's why we are pretty focused on that for COPD patients. That's not really what you believe, but that is a fact. What we found in self-reported physical activity at 3 months was that the intervention group, as you see in the black, almost half of the group increased their physical activity level compared to the control group that the majority decreased their level. The same was found in another questionnaire on physical activity, where the intervention group actually got closer to what Socialstyrelsen recommend for the general population in activity during a day. But as you know, this is self-reported data, and we always overrate when we talk about physical activity, as well as we underrate what we eat. So we are well aware of that, and we had activity monitors, proper validated activity monitors for a subgroup, and we cannot do statistics on that because there are too few, but the trend is similar to what we found in the subjective reporting, that the Coolwebben group increased activity level and the control group decreased. Actually, the results at 12 months were similar, so the difference between activity level was the same at 12 months. We also wanted to look at Coolwebben, the possibility to use Coolwebben in home health care, because COPD patients are, of course, all over the spectrum of health care. So we redid the involvement process with staff in home health care, and according to that, we built an education section on Coolwebben with 6 modules with different themes that they were able to use during a 12-week period. So 40 people working in home health care used this, no, not 40 patients used it, but they were evaluated in their COPD-related knowledge by a questionnaire, and 22 persons used Coolwebben, and 18 persons were acted as a control. And what we found there was that the COPD-related knowledge increase in those people, with those professionals who had access to Kolwebben in this educational way. And this was significant both within and between groups. So Kolwebben seemed to be a way to improve and increase knowledge on COP. We have an ongoing study. The first one was a pilot study, and now we of course want to do a proper powered randomized controlled study, and we do that actually now. It's ongoing, and we collect patients from all over Sweden in primary care. And the primary outcome is objectively measured physical activity to see if Kolwebben could be an instrument, an e-health tool to change behavior regarding self-management strategies, especially physical activity level. These days, I should talk a little bit quickly about implementation, which is a huge problem of this. But now Kolwebben is at a Swedish webpage called 1177 Vårdguiden, which is a webpage where both patients and staff seeks for information. And if you look at you see Kolwebben there as a tool that you could go into. As you know, these things are not done by one person. I am happy to have a large group of people working with me together in this project. And we also have founders like Vetenskapsrådet and the Heart and Lung Foundation, the patient organization, and also other smaller foundations. What I wanted to end here was that we, during this Congress, have we have formed a network for tele-rehabilitation that we called Nordic Research Network in Tele-Rehab, or tele-rehabilitation, and short Nordic tele-rehab. We were working on this yesterday, and these are today the members, so to say, that has got research connection. What we want to include is also a healthcare group, of course with clinicians, even though in the name it says research, but we don't want to exclude clinicians who are interested in working with this, because as a clinician we should always work according to research, so it's not meant to exclude anyone. And we also plan to have collaboration with industry to be able to do the best development of new strategies. The objective of the network is to create an arena to gather research institutions, clinicians and companies from the Nordic countries which work with or are interested in the field of tele-rehabilitation. And we have, yesterday we have come out with a working plan, an action plan for doing that. So I hope that that will be a successful network, and that hopefully you will hear more from that network, and you are also welcome to join if you have a specific interest, of course. Thank you very much.
There is also time for questions, if anyone. Yeah, please one.
Hi Karen, thank you for a very nice presentation. I was wondering, now when you are testing in a larger scale, is that done on patients who are participating in rehabilitation in healthcare centers, or are they using it as a standalone, or how is it working, and how many patients are you including?
Very good question. They are or rather exclusion criteria is if they are included in any ongoing pulmonary rehabilitation program. They are not supposed to use Kolwebben today. We have sort of got stuck in a interesting problem, because we wanted to open the web page because it came rather similar, and we wanted to release the web page.
or actually we were not allowed to close it down after the study, because the staff who used it got just, they said, you cannot take that away now, because we use it as a tool, which we, as I said, the result from the staff is not done yet, but that is one result. We were not allowed to take it out. So what we did now is that we have, if you go into coolweb.se now, you will be met by, you have to have a code to enter. You can get it if you want, if you just email, and then the study group will, or we, will give you the code, but we have to control it. So the question of, they are not included in any other rehab program during this period, and we plan to include, according to Power, include 144 patients and randomize according to that.
Thank you very much, Karin.
Thank you.
Last speakers, we have two Norwegian coming up at the stage. That is Ingebjørg Irgens and Hege Brag-Øra from Sunnaas. I guess you present yourself more deeply, but we are going to be presented how Sunnaas is working on tele-rehabilitation.
Thank you. Well, thank you very much for letting me be here today and present for you. So, my name is Hege Brag-Øra. I'm a medical doctor and a PhD fellow at Sunnaas Rehabilitation Hospital, and together with my colleague, Ingebjørg Irgens, I will present for you today how we use telemedical solutions and telerehabilitation at our hospital. This will especially be exemplified by two ongoing PhD projects. And I will start off this session just by giving you a short presentation of Sunnaas. At the Sunnaas Rehabilitation Hospital, we offer multidisciplinary rehabilitation to people with complex functional impairment following illness or injury. We are Norway's largest within research and innovation staff within rehabilitation. And we provide services at regional and national levels. And these are our key numbers. We have 159 beds, 3,150 discharged patients each year. So we are one of Europe's largest rehabilitation hospitals. With both regional and national responsibilities, we have patients that are spread across large geographical areas. And one of Sunnaas' main goals is to ensure the best possible rehabilitation for our patients. And we know that the cooperation around a patient's rehabilitation process requires coordinated efforts from many participants. And we have therefore, at our hospital, quite early on been aware of integrating telemedicine solutions in our clinical practice to facilitate better services. We have developed our own model that we call the Sunnaas model, where the use of video conference has played a central role. Video conference is then used to make the services more accessible and coordinated with partners like the municipalities and other hospitals or rehabilitation institutions. And video conference, well, this is a media that is, for most people now, quite familiar with the use of FaceTime or Skype. But by definition, this is a two-way audio and video connection that can be used when multiple parties communicate across geographical distances. What is important to remember is that in the healthcare services, such communication must be encrypted to ensure that sensitive information is not compromised. So in Norway, Skype and FaceTime are not allowed for communication with patients because we don't have approved encryption. Skype for Business is approved in some regions, but not in others. At Sunnaas, we use video conferencing in meetings, where video conference equipment is installed in most of our meeting rooms at our hospital. Video conference is then used in multidisciplinary meetings before, during, or even after admission. Video conference is also used in course activities, both for the health professionals and patients and relatives. And this is perhaps more traditional use of video conference that is quite known to many. At Sunnaas, we have now also seen opportunities to more integrate the use of video conferencing in more clinical settings. An example of this is the interpreting service. We now offer interpreting by screen, and we also use it with regards to isolation rooms, where patients are isolated due to infection and then can participate in meetings and be able to take part of their own rehabilitation process through video conference. We also use video conference. We also use video conference for patients, consultants with specialists in other hospitals. Excuse me, I'm going to go. Yeah, excuse me. This is it, yeah. We also use video conference for patients, consultants with specialists in other hospitals. For example, pressure ulcers or burn injuries that needs plastic surgeons. And we provide consultations with the outpatient clinic through video conference, where we then use the patient's computer or laptop in their own homes for consultation with the outpatient clinic at Sunnaas. We also have clinical video conference equipment that can be used in clinical settings. This is connected to Norwegian HealthNet and can also be connected to medical devices like stethoscope, ultrasounds, or camera. So, in line with the future's way of providing healthcare services, we have this last year also looked at the opportunity to conduct active training and rehabilitation through video conference at Sunnaas. And this may be applicable to both training of cognitive function, motor function, and it could also be used in speech and language training after brain injury, which will be the further focus of this presentation. Aphasia telerehabilitation post-stroke is my PhD project, where we further explore the use of video conferencing in speech and language therapy. And this is for then people with aphasia following stroke. And aphasia is a disturbance that we see in 25% of all stroke survivors. The project is funded by the Southeast and Norwegian Regional Health Authority and University of Oslo, and also Sunnaas Rehabilitation Hospital. And the time frame is over 4 years. I'm the PhD fellow in this project group. We have then speech and language therapists at Sunnaas that has been providing for the intervention. And supervisors is Frank Becker, which is the main supervisor. He is our head physician at Sunnaas, and also an associate professor at University of Oslo. So why the use of telerehabilitation in speech and language training? Why have we initiated this project at Sunnaas? Well, we see that in rural countries like Norway, ensuring individual tailored aphasia rehabilitation of sufficient intensity and duration is quite a challenging task. Norwegian guidelines for treatment and rehabilitation of stroke recommend quite a fast onset of speech and language therapy at a sufficient intensity of at least 5 hours a week. Aphasia services in Norway seems, however, not to be in line with this guidelines. And an early start of aphasia rehabilitation at satisfying intensity do not seem to be provided. And there are many reasons for that. This is due to geographical challenges. There are limited capacity for rehabilitation at the community level, and there are a lack of speech and language therapists. Many municipalities do not even have any speech and language therapists employed. So with this in mind, we conducted in 2012 the feasibility project Language Training Straight Home. And the aim of this study was to evaluate telerehabilitation as a possible delivery mode for aphasia rehabilitation. And this pilot laid the ground for our current trial. So, aphasia telerehabilitation postdoc is a trial that has a pragmatic, prospective, randomized control design. And we have a telerehabilitation group and a control group. And both of the groups receives standard aphasia rehabilitation. The telerehabilitation group receives speech and language therapy via video conference in addition to usual care. And we give the intervention with quite high intensity. The intervention is given 5 hours per week in 4 weeks. The video conference is delivered by the Norwegian HealthNet. We use Akano. We also use LogMeIn, which is a remote control software that allows the speech and language therapist to make and take over the patient's computer, which is very valuable in this form of training. Our main aims with this trial is to look at the clinical effectiveness of speech and language therapy in addition then to standard aphasia rehabilitation. We want to explore the quality of life and we want to look at the feasibility. Is telerehabilitation sustainable and feasible with regards to both ethical, technical, logistics, patients and data safety aspects? And the project has now ended their intervention in June this year. There are 62 patients that has been included in this trial, and we have now performed over 550 hours of speech and language training by video conference in this project. So the last data came in this September, start of October. So we are now currently analyzing the data and very eager to present as soon as they are ready. And I'll give the word over to Ingrid Rigens to further now present her PhD project on pressure ulcers.
Yes, hello, I'm Ingrid Rigens, and I will try to tell you a bit about another research project at Sunnaas. This is a project funded by the Extra Foundation, and the equipment is funded by the Sunnaas Foundation. And the time frame is almost the same as in Hege's project. I'm supposed to be finished by Christmas next year, and I cross my fingers. There are a lot of data to analyze. I'm the PhD fellow, and I also have the interdisciplinary team at Sunnaas working together with me, and I have my supervisors. We have patients and also the municipality home care nurses participating as users in this project, because we think it's very important to get their feedback. And we have ongoing feedback from them, and we also did a pilot, I will come back to that, with a lot of feedback from the users, which was very important for us. This project, pressure ulcer project, is about patients with spinal cord injury and pressure ulcer. We don't know the exact number of pressure ulcer in this group, because this number has never been accounted for. So I'm doing this as a part of my PhD study. And so far, the number of patients having had or having a pressure ulcer is about 20, but I'm still counting. The average number in the general population in hospitals in Norway are between 7 and 13%, so we can see that the number is much higher in this group. I am doing this project as an RCT with one control group and one intervention group, and the only difference of these two groups are that the intervention group are followed up by the use of video conferencing. Other than that, the follow-up are exactly the same. They have the same offer, and of course evidence-based treatment. We have questionnaires at the start and at the conclusion of the study, and at the conclusion we have a questionnaire about user involvement and participation and cooperation, because it's important for us to see if this follow-up can involve both the local home care nurses but also the patients and their next of kin in a better degree than what is today's treatment. We follow them for 12 months, but of course that's the project follow-up. They will be followed up further on if the ulcer is not healed. Yes, and what we think is that the use of video conferencing will give a good and secure way of follow-up, and that is in when it comes to both healing, participation, cooperation, quality of life, and also socio-economic and environmental effectiveness. There are a lot of things here, so I think there could be data for at least 3 PhDs. We did a feasibility study back in 2012-13, where the aim was to see, is this possible? Is it possible to use video conferencing as an outpatient tool in the follow-up, so that the patients can be followed up from his or her own home instead of coming to the clinic, to the hospital to get their treatment and follow-up. We also saw that there are very varying degrees of knowledge in the municipalities. Some of the local home care nurses are very educated when it comes to ulcers, but some of them are not. And when it comes to the combination pressure ulcer in the group of spinal cord injury, there are certain things that one should be aware of, and this is why we wanted to work evidence-based from the same professional platform. And the patient wanted this. They told us back in 2011-12, some of the patients told us, we don't want to stay in hospital anymore. We want to go home. We will see you on Skype. So, and then made us think, can we do this in a way that also is legal? This Hege has told you about this, and we got from the feasibility study we got some feedback, and this feedback told us that yes, it can be done. It is possible to follow up, and the feedback from both patients and their local home care nurses said that they felt safe and secure, and the ulcers healed, and especially the patients, they told us about this continuity because they felt that they got the same treatment. Earlier they told us that if in a period of 3 weeks maybe 20 different nurses had been in their homes and had suggested 20 different ways of follow up the ulcers, and of course the ulcers doesn't heal. They don't heal if the treatment varies this much. And we saw that the ulcers heal. I don't think that video conferencing will make them heal easier. They will heal the way they are supposed to heal, but making this a bit more systematically and make it more continuously, it will maybe shorten the time of healing. It takes a long time for these ulcers to heal. We also did a cost-benefit. This was a small feasibility study, so that the numbers, it just gives us something. Yeah, it tells us something, but we need a larger number of patients to have a better examination of this. But as you can see, this is the difference between outpatient treatment and video consultation. And here it comes when it's inpatient treatment compared to video consultations. But what did we learn? Yes, we learned that there are a lot of positive effects. And this video conferencing fits long-term follow-up, and also it fits follow-up of patients with complex needs. But there are also some negative things. This has been mentioned earlier in this session, but also it is time-consuming to coordinate, and we don't always know who should we ask out in the municipalities, who is responsible for giving us permission to do this. We also want to get paid for what we are doing, and this is something that the health authorities should be aware of. If they want us to use new technologies, they should also make it possible to do it economically. And also we have had difficulties with reaching out to the GPs. So this should be considered in particular. As I already have told you, there are a lot of possible advantages. And both when it comes to money, but also climate. If the patients drive less, they will not pollute, if we are taking this out to the complete population and with pressure ulcers, then it will be a huge number of saved transportations to the hospitals. And this will also free capacity at the hospital, so that other patients can get treatment instead of ulcer healing at the hospital, because ulcer healing at the hospital, that is just lying in a bed to get the ulcer healed. Yeah, and this is how to succeed. Onsdag and Begge Jensen has brought something about that, and this is also what we found at our hospital. We have to integrate the use of new technology in our daily routines, and it's important to have a hotline for the clinicians to use when it comes to getting service and support, especially in the first part of using video conferencing, and to continuously think of, we need to improve. Even though we get good feedback, we need to improve. The leaders need to be involved, and we need dedicated clinicians. And the red lines here are my take-home message to you. We need to run these projects as projects for the benefit of patients, not as IT projects. And here are the overall objectives: the right treatment, the right patients at the right time. That is what is important. Yes, thank you.
Very much. And, I think, well, we are competing with the lunch, so I think we may save the questions for those of you who can contact these people after. And thank you for being here, and thank you for all the presentations, all of you. So it's lunchtime. Thank you.